This conference will now be recorded.
At this time, I would like to introduce you to our speakers. Sally Bucks joined the Center over 20 years ago and currently serves as CEO. She provides leadership and program development for rural health issues at the federal, state, and local level by analyzing rural community, hospital, and network needs to improve rural health care. Sally provides technical assistance in performance improvement, health information technology, network development, population health, and workforce for rural providers. Sally serves as liaison to the Federal Office of Rural Health Policy and other national rural health organizations and represents the organization on appropriate rural health committees and boards. Tony Ann Richard is Executive Director of the Healthcare Collaborative of Rural Missouri, a rural health network supported by the multiple funders, partners, and investments. She has over 20 years of experience in nonprofits and working with community networks. In the last 4 years, her expertise has been instrumental in successfully implementing and launching programs that improve access to healthcare delivery to underserved populations. Her career goal for the organization are to successfully develop a sustainable rural health network for providers and is working with HCC's network to develop highly effective service delivery models for vulnerable populations. Healthcare Collaborative of Rural Missouri is the only healthcare network in the country that operates not one, but 4 federally qualified health centers. Maggie Sauer is the President and CEO for the Foundation of Health, Leadership, and Innovation. The foundation creates opportunities for its programs and local communities to address whole person, whole community approaches, integrating health, economic development, and social determinants. Prior to joining the foundation, Maggie served as Associate Executive Director of the North Carolina Medical Society Foundation, directing programs to strengthen and expand primary care in North Carolina. Under her direction, the North Carolina Physician Institute for Quality Enhancement Fellowship was established to support quality improvement in the processes by which specialty medical care is delivered in North Carolina. Prior to that, Maggie was Director of Health Promotion at Duke Division of Community Health, where she led statewide chronic disease prevention and reduction programs in 67 North Carolina counties. Now I will turn it over to Sally, Maggie, and Tony Ann.
Thank you, Kim. Welcome, everyone, including our small rural hospital transition hospitals, our state partners, and the network development grantees, and the small rural healthcare quality program. And our webinar today is the first of our new program year. So we're happy to be able to start off with focusing on rural provider leadership and engaging providers in the transition to value. And the center providing today's webinar and the organization with Rural Health Innovations has the support of the Federal Office of Rural Health Policy for the Small Rural Hospital Transitions Project. And we provide education through this project as well as on-site technical assistance to assist bridging the gaps between the current healthcare system and the newly emerging healthcare delivery and payment system. And the center brings a number of years of experience in technical assistance, and our focus the last few years has been supporting small rural providers and state partners in the transition to value and population health, and this certainly is the focus of the Small Rural Hospital Transition, or SRHT program as we call it. Also, we work in collaboration and partnership technical assistance with network grantees. We provide performance improvement technical assistance through the Medicare Rural Hospital Flexibility Program and a program called TASK, working with the 45 state flex programs to support critical access hospitals. And also we work with all 47 states that have small rural hospitals through the Small Rural Hospital Improvement Program, also known as SHIP. And we also provide services in TA and health information technology and workforce. Our presentation today will focus on learning about the drivers and challenges related to engaging rural providers and value models. We'll explore the strategies for engaging rural providers in value and population health initiatives. and discover the resources for state flex programs as well as state offices of rural health and networks that they may use to support rural provider engagement. And our focus for the webinar will be sharing the findings from a Rural Provider Leadership Summit. And this was supported by the Federal Office of Rural Health Policy. The center convened the summit in May of this year. And the purpose was to identify strategies for rural provider engagement and transitioning to value-based models. The center has conducted several summits the past 10 years with the Federal Office of Rural Health Policy to bring together key stakeholders or key informants into a small group meeting, and it's around a topical issue applying to grantees. We've held summits on networking, quality improvement in critical access hospitals, critical access hospital finance, and population health are a few of the summits we've held. And at the summit held in May, we have also attendance by our project officer, Mike McNeely, for our cooperative agreement, which funds the SRHT education and training programs. And we definitely have, in this cooperative agreement, feel that the Federal Office of Rural Health Policy is very attuned to the special assistance needed by rural providers, whether it be networks, clinics, community health centers, individual providers, and communities to make that transition to value and population health as their payment or reimbursement is still in a fee-for-service volume-based environment, that it is taking some innovation and looking at what the needs are. So the summit is a key way to do that. So we started off the summit by identifying the opportunities and challenges related to engaging rural providers in value models. We identified and prioritized the key strategies and actions rural hospitals can take for engaging rural providers in value and population health initiatives. And finally, we shared examples of successful models from the summit participants across the country and from different perspectives of examples or best practices and also lessons learned. And we also identified resources available as well as resources needed to support implementation. This is a list of the summit participants, and you can note the variety. It included 4 physicians. They were all family practice, a nurse practitioner educator from Alaska. We had 2 networks, one being a Tony Ann Richard, her network in Missouri, as well as Kathy Johnson, who just recently retired, started a critical access hospital network in southwestern Minnesota, and she was also CAH administrator. We had paramedic, 2 state offices of rural health flex programs from Michigan and South Carolina. And also we had a clinic administrator from Kentucky, and also a rural health value. Carla Wang from Stratus Health represented rural health value and actually was the writer for our summit findings. This is a picture of the group. After we had done the work of the summit, we used an interactive facilitation method, and behind the group are 2 different sticky walls with all of the drivers, challenges, and strategies identified throughout the process. Well, the summit was convened because of the change in the move to value and the alternative payment models. And this is an illustration of the targets that the Department of Health and Human Service is looking at in terms of moving from fee-for-service, and that would be all Medicare fee-for-services in the larger gray circle in 2011, and you can see the goal is to move that to a smaller and smaller portion over the next or beginning in 2011, but for now that we're in 2016, this is actually only 2 years out, that 90% of our fee-for-service payments to providers would be linked to quality, and half will be in alternative payment models, such as accountable care organizations, bundled payment models, patient-centered medical homes, so alternative payment models. And actually in 2016, going towards 30%, and HHS has already announced just last month that that has been surpassed. So we're already moving, the market's moving quite quickly towards the alternative payment models. So the market is changing, as well as in terms of the products and payments, but patients are also looking for better outcomes. So it's a new era of healthcare, certainly driven towards better care in terms of quality, improved health of communities and patients, and controlling costs or smarter spending. So sometimes referred to as the triple aim, but those three imperatives are moving us towards value. What is unknown is this little gray, slender part of the circle in 2018 is the models and methods for critical access hospitals, federally qualified health centers, rural health clinics, who are in that fee-for-service or cost-based reimbursement, of how they will fit in this movement to value, knowing that is the overall goal, but the exact structure isn't known there. But from our work with hospitals and working with the Federal Office of Rural Health Policy, there's a recognition that physicians, the key primary care providers, physician assistant, nurse practitioners, mental health providers, paramedics, who are key in rural communities, are not aware of how rapidly this is changing in terms of the overall market and the potential impact to their care provided in rural communities, and that there was this gap between how fast it's happening and the hospital leadership is hearing about it, seeing it, and the providers having an understanding and being engaged in this process. So that was the issue that rose up, that we felt this summit was needed. We began the summit by identifying the driving forces in the market, which could be seen as positive or negative, and then the transition challenges, especially for rural communities and their provider engagement in value-based models. And on the left side, see there's initiatives coming from the Centers for Medicare or Medicaid, such as State Innovation Model grants, ACOs and other alternative payment models, more quality payment programs such as MACRA and MIPS, increased data transparency, patient and community expectations, characteristics of a new generation of providers, millennials, and their interest or lack of interest in running a practice in the business, and the increased consolidation that providers are more often employed than being in an independent practice. And then on the other side, the other forces being the challenges of up against all these market-driven forces, lack of funding and investment capital in rural areas, leadership tension, the change fatigue. There is so much happening. They're just kind of rolling through installation of electronic health records and meaningful use, and now facing changes in payment and reporting, limited data capabilities, population shifts and out-migration that continues in many rural communities, the shortages of providers and expertise, and then limited time and trust. So I'd like to turn to our summit participants, Tony Ann and Maggie, See if they have any comments from the discussion on forces and challenges. Maggie or Tony Ann, it's star 2 to unmute.
Sure. Can you hear me now, Sally? Sally?
Yes. Yep, I can hear
Okay.
you.
Great. Sorry. Yeah, this is Maggie Sauer. In North Carolina, we've certainly seen the compilation of the forces sort of battling with each other. One thing we have seen, though, is the fatigue that's described also gives way to an opportunity. Sometimes the providers in North Carolina have been so fatigued by even doing fee-for-service work that, particularly in rural areas, they're beginning to think about the opportunity of value-based care, working with larger teams, and people are starting to see the relief that that might bring, because it does include a broader number of team members to support their work. So I think that transition is difficult sometimes, but just based on the need and what's happening with critical access hospitals in rural communities, people feel like they need a team around them, as much support as they can get, and value-based care can add that for them.
Thank you, Maggie. Tony Ann? It's star 2.
Hey there, this is Tony Ann. Can you
Yep.
hear me now?
Yep.
Thanks. Okay. So, I mean, I'll definitely echo what Maggie said. And, you know, also I think as an FQHC that works directly with hospitals, health departments, and different other private practice providers, other safety net organizations, one of the things that we are looking at is really streamlining those quality measures, those quality indicators, to help transform the system within our region, to make sure that those quality incentive-based payments are being maximized across all of our network members. And so some of the things that we've talked about is specifically around ACOs and the alternative payment models, is taking a look at a shared savings component of that back to the providers. So if specific goals have been met or indicators have been met, what's the financial incentive for those providers? We have not put anything into practice, obviously, at this point. There's a lot of conversations that still need to take place, specifically around bonus payments and what does that look like. But that's where we are in the discussion. The other is really, where's the accountability on the patients? What resources should we be providing to them for accountability, and then what resources should they be providing to themselves? So having those discussions internally and externally have been helpful. And then I would just end with some significant training around MACRA and MIPS. It's overwhelming even to our most seasoned hospital staff. So really just getting in front of them as often as we can with experts to talk about it and see what we can do.
Thanks, Tony Ann, and thank you, Maggie, for those examples. Well, as we began to work as a group to look at strategies, we decided to frame that within looking at this holistically and through a system lens. And the Center has adopted the Performance Excellence Blueprint, which is modified from the Baldrige framework, and we have used that in our work in technical assistance with state flex programs. We recommend that for critical access hospital success and network success and sustainability, that it is so important to be aware of all of the factors of a quality organization, and that the information is fed back to leaders for ongoing improvement in these areas. And we know that hospitals especially have so much information, so much data, and sometimes they struggle of what's most important to note in terms of meeting their goals. So if they're looking at the success or measures within all these areas and making sure there's feedback loops even in physician engagement, that it's a systems approach and not just working directly with medical staff and their compensation, but this really impacts the whole organization. So we introduced this framework or blueprint to the group, and then also the physician engagement, and this was a primer for healthcare leaders produced by Rural Health Value, and that is a program supported also by the Federal Office of Rural Health Policy, and they developed a primer for healthcare leaders and actually included an assessment of looking at physician engagement. And the 4 key categories of organizational culture related to engagement were these 4 governance, including making sure that there is provider leadership as part of the overall hospital leadership. Physicians like to be in the room when big decisions are being discussed and talked about, and we're seeing more models of a blended leadership model, administration and provider leader. Education was the next key area that Rural Health Value noted in terms of making sure there's education on the transition to value, that your providers have mentors and they have support for executive management if you're looking for certain providers to be your champions as you move to value in different care models, is identifying a champion. This was the same with the adoption of electronic health records, that it was recommended to find a physician champion or a nurse champion, a clinician who could see the benefit of this change and could help convey the benefits to their other peers. Compensation, we are seeing increases in primary care pay, like huge increases from what we saw even 5 years ago, as primary care providers are key to population health management and care coordination. And we're seeing that more compensation agreements, contracts are putting an emphasis on quality, but also make sure that the time for providers to be involved in teams and looking at quality data, that is compensated, as well as communicating expectations of time. And finally, data. Providers generally like data and are somewhat competitive, and so we have seen success from clinics and hospitals sharing the information with their providers, whether it be customer satisfaction scores, immunization scores, following evidence-based practice, that this helps provide the information on where this is going and what the clinical goals are. So this is we have a link here to this tool as well. And both the blueprint, performance excellence based on the Baldrige model, and this primer have assessments to help hospitals gauge where they're beginning in this transition to value. So then finally, then the panelists, after looking at the market changes, then we moved into what strategies are needed to react to these market forces and address some of the challenges as we move towards value, and how do we engage providers. And a number of strategies were identified, and then we clustered those together and identified the top 10. And then also we had the participants rank of what was of the highest priority. And these 5 were listed in priority. The first one being creating a shared vision of value and understanding the role of providers in the transition. And the discussion around this strategy was the need for hospital leaders to be willing to invest time and the resources to help providers with education and facilitating discussions. The second one was examining various models and approaches towards value, that leaders should seek funding opportunities through demonstration models, and it's things like the ACOs and shared savings, state innovation model, federal Office of Rural Health policy grants, and also the technical assistance available through the Transforming Clinical Practice Innovation, or TCPI, types of grants. So look at the approaches within your region, your state, and what is available at a state level as well as nationally. Investing in provider leadership, and this was key, that it be both time, money, and education, and to align those pursuits of the hospital's vision of value. And number 4, partnering with others to capture and share data. And several of the summit participants shared stories related to that critical role of capturing the data, sharing that with their providers, especially claims data that they've never had before from Medicare or Medicaid, be totally eye-opening. And then number 5, develop collaborative relationships and connect community resources to address patient needs. And certainly a growing recognition, many of the factors that impact illness and healthcare spending are outside the scope of traditional healthcare in the clinic and hospital, community health center. It's that the mental behavioral health needs are so key, socioeconomic factors, and then individuals' habits and behaviors all have a significant impact on their well-being and their ability to manage that chronic illness. Then there were 5 additional strategies I identified. Number 6 being redesign operational processes for value and population health. Be looking at working with the providers to have extended hours, e-visits, using patient portals. 7, develop skills and organizational capacity for team-based care, really defining the roles and distributing tasks across the team members to reflect their skills, their abilities, and credentials to improve care, and also to reduce provider stress. And 8, seek opportunities for collaboration and synergy with other providers and organizations. The group really felt networks were key, membership organizations, other affiliations, with other professionals facing similar challenges, either within your region, your community, or your state. So these could be more vertical type networks within one county or community, or a whole region or statewide with other community health centers or hospitals. 9, telling your story. We felt that just the story shared within the summit of the 14 participants, they all felt that was of such great value to hear with different parts of the state and different models what they were discovering and trying. So it helps inspire other rural providers and leaders, but also helps in policy and rulemaking. And 10, advocate for rural payment policies that adequately address our rural community needs, certainly with a lower volume as we move to value-based models. And some of the comments that are captured here from participants as direct quotes. through these strategies and certainly reflect that rural perspective. It's something that has to start and grow. It's not going to happen overnight. We all have to own it. You have to share data shamelessly with everyone, even the public. And finally, we need to get to our patients, not just my patient, in team-based care. And now we're going to turn to our participants from the summit. We have Tony M. Richard from the Healthcare Collaborative of Rural Missouri. And Tony M's going to share a success story from their network, and then we'll have a few questions for Tony to elaborate on rural provider engagement. Tony M?
Thank you. Like Sally said, my name is Tony Ann, and our network and FQHCs are located in Missouri. We're closer to the Kansas City side of the state, and so we do, while we're aware of the Kansas and Missouri borders, most of our programs do fall on the Missouri side, although we do collaborate some with the larger systems on the Kansas side. So we definitely have a diverse vertical network. We were formed about a little over 10 years ago, and the network was originally developed to help recruit providers into the community. And what has happened over the course of the last several years is how payments have changed, specifically for rural health clinics in our area. We had 2 rural health clinics that were potentially going to close that were owned by the Critical Access Hospital. That hospital actually donated those clinics to the network for us to convert into FQHC lookalikes. We pursued that route along with the full funded FQHC model and began services in June of 2013. And so what we've been able to do is develop significant relationships with other hospitals in the area. We recently opened a 3rd and 4th site, one of which is on a Critical Access Hospital campus. We lease providers from them. We share some lab services. We have agreements in place for emergency department diversion, the Medicare follow-up visits for unassigned patients, and different programs specifically around medication management, psychiatric services, and referrals. So we have grown significantly. About 10 years ago, we had myself and another part-time employee, and right now we have almost 70 staff, as well as several contractual providers that we lease from our hospital partners. So one of the things that was important for us as a network is that we not duplicate services in rural communities, but we enhance those services and find ways to be mindful of competition. That competition certainly did not go away. We have very honest, frank conversations around the table, specifically around recruitment, services to provide, et cetera. There is a decent level of trust that happens among those hospital partners with each other. HCC definitely has been able to mold some of those relationships and allow people to sit together at the table to address those gaps in service. Typically, because we are a network, we become the guinea pig, for lack of a better word, to test new services, test new programs, look at different innovative sites. We are able to be a little more risky in terms of the logistics around healthcare. And so what that has done is really brought people together to address the common challenges around the rural services. We've had significant conversations around ACOs, shared savings models, etc. We have not made a commitment to an ACO at this time, as we're not really sure who's on what page yet. So this still definitely in a learning environment. I have 2 hospitals that have HCA affiliation, and so that causes a little bit of higher level conversation around HCA's position on ACOs, which at this point, unless something has changed in the last 30 days, they have decided not to move forward with that. So we try to be very careful about respecting those relationships and those partnerships, and making sure that we're all working towards the same goal. So Sally, I will turn it back to you.
But Tonya, do you want to elaborate on the, so since you haven't moved into ACO, but looking at certainly through your grant activities, what do you see as the key challenge of getting rural providers to kind of take that risk with you, because they're employed by the network of moving towards value-based models?
Sure. So we talked a little bit earlier about looking at the contractual agreements with those providers, the employment agreements, and building quality metrics into their contract, and then also looking at a bonus structure for those providers based on services provided through a value-based network. We have we're very much an aging provider community, so looking at recruiting newer providers to come in and take over as those more seasoned providers are looking into retirement, and really being mindful of the technology barriers of our more seasoned providers, and what does a shared savings model look like for them, and the value-based performance. Do they have the capacity to change their practice at this point? What resources are needed to be brought in for that? And a lot of education, helping providers understand those expectations. What is expected of them, what is expected of their nursing staff, what is expected of the administration, who's going to provide what support. So really sitting down and working through those in-the-weeds details with those providers, as opposed to developing something at a 30,000-foot level and then working to implement it on the ground.
Mm-hmm. Okay. And how do you anticipate, or how have you seen this perhaps already, that the practice style is changing for primary care providers?
Well, because we are a federally qualified health center for direct services through the network, we have quite a bit of integrated care already, specifically around dental and behavioral health services. So some of that has been existing and working by design of the program. When we think about our hospital partnerships and relationships, looking strongly at those referral agreements that are required for FQHCs, and putting language in there, and probably more importantly, putting into practice some of those measured outputs and outcomes, and then getting in front of med staff committees, in front of quality committees at those hospitals, and talking through the data. What data are they collecting? How are they collecting it? How can we as a network help them? And then how can we use our lessons learned on the FQHC side to help them avoid any barriers or lessons learned that that maybe we learned the hard way. And so just that constant communication, constant circling. We added a director of nursing position this last summer, and her main priority is getting people services in the right place at the right time by the right provider. And so she's linked in heavily with our hospitals and rural health clinics and working on the emergency department diversion piece right now. But an important part of what she does is learn the value-based quality reporting measures. So we're constantly feeding that pipeline of information and education.
Okay, great. Thank you. And then I know a piece that you wanted to share with the group was in terms of demonstrating economic impact as you're looking to further integrate rural services, especially safety net services and oral health, behavioral health, as well as primary care. Do you want to walk the group through these, please?
Sure. So the slide that you see right now is the second economic impact report that we have completed based on our UDS measures. And one of our promises back to the network members and our communities was that we improved the economics around health care in our community, as well as improved savings tremendously to the healthcare system. Right now, 2015, you can see the $4.4 million that was saved to the healthcare delivery system from last year. And while we're working to reconcile that back to the emergency departments and the hospitals and some of the write-offs for the other private practice clinics and even some rural health clinics, we know that is significant. We have more people are coming to the table wanting to partner with us around getting patients care in the right setting at the right time, and so working towards the whole wellness component piece of that. So I think one of the things to look at also is our patient profile. 95% are under the 200% of the federal poverty level. Roughly 60% are under 100% of the federal poverty level. So it's very safe for us to assume that over half of our patients prior to opening the FQHC through the network was receiving a lot of primary care through the emergency department. We probably won't be able to reconcile those savings for another year, as we want to look at trends with our hospitals in terms of what their write-offs were at different levels. But we felt that it was very important for us to promote this information as it relates to the partnerships in the community. One interesting piece of this is that in 2015 we had created 48 jobs, and in a rural community we have about 30,000 people in our county, about 120,000 people in the service area that we serve over a 4.5 county radius, and we are now up to, like I said earlier, about 70 jobs, as well as some indirect positions.
Okay. Great. And your indicators and benchmarks are shared here from the staff, which is great, as well as patient satisfaction.
Right.
Encounter. Yeah. Thank you.
Right. And I think one of the things we made a strong commitment to was our key performance indicators for staff and for patients. That's relatively new. We've been monitoring that for about 18 months now, and our numbers for 2016 are improving. So the UDS encounters, we had a 25% increase from 2014. Our 2017 targets is about another 50% increase from 2014. So we're expecting to continue some tremendous growth.
Thank you. Great. Now we'll hear from Maggie Sauer from the Foundation for Health Leadership and Innovation in North Carolina. And Maggie, I'll use some time here to share a success story lesson learned.
Great. Thanks, Sally, and thanks for the opportunity to talk with everybody. North Carolina, as you've heard too many times probably in the national news, is an interesting place right now. But some of the things that our value-based care structure is based in is really a Medicaid reform initiative underway across the state. And luckily, some of the things that are included in that Medicaid revision and in a new Medicaid waiver that was submitted to Washington and CMS was this notion of value-based care, of making sure that within this system that providers would be cared for and nurtured in terms of recruitment and retention. But overall, the system in North Carolina will go towards a value-based care system. And it's been that kind of overarching initiative that has really forced us to begin to look at how do we do this. And to the degree that so much of our hospital system has now become systematized, it really does go to each of us to think about how we preserve the rural support that our critical access hospitals and so on need within this particular kind of an environment. One of the things in North Carolina specifically is that we do have a system of care that's our Medicaid provider that's called Community Care of North Carolina. There's many pieces of the ACA that have actually been created based on some of the work that Community Care of North Carolina has done. It has 14 networks across the state of North Carolina, and they literally, each network, the practices that are included in that network across the state receive a per member per month payment for each Medicaid patient that they provide service for. So there's been some interesting ways in which those networks have begun to work specifically with their hospitals in their local communities to make sure that folks are getting the best care they can at the right place and at the right time and with the least expense. So one of the examples that I wanted to provide today is actually an initiative that's underway in the eastern part of our state right now. It's more poignant, I think, today because, as you have probably heard, North Carolina got hit really hard with the hurricane and the surge waters and things that are still affecting our state, and we won't really know the result of that until probably the end of the week, just because of the way that rivers drain and so on. The reason I bring that to your attention is because the group that formed about a year ago now, in response to the Centers for Medicaid and Medicaid Services Innovation Grant, the Accountable Health Community, was a realization by folks in eastern North Carolina that there was a lot of fatigue by providers because in a fee-based system they felt as though their job could never get done to the satisfaction and to the best results for their patients. And people, providers of all types, community agencies and so on, were just being exhausted. And the group came together as the North Carolina Eastern Health Stewards for the region to respond specifically to that CMS application. And what we've seen happen since then, one of the unfortunate things was that our Medicaid office prevented application of the state agencies and so on, and the foundation being one of those, in terms of going forward with the application until the last minute, and the secretary lifted that. But the more important piece of it was it allowed a discussion around how critical value-based care would be for the community, for the people who are engaged in patient care in Eastern North Carolina, because it frankly has given people the opportunity to do what they do best. And in rural settings where people come together, utilize resources in a way possibly they hadn't imagined before. And so what we found ourselves doing was working with the hospitals in Eastern North Carolina, the community care networks in Eastern North Carolina, the social service agencies in Eastern North Carolina, to begin to talk about how can everybody work together, share data, and create outcome measures that would demonstrate the effectiveness of that partnership. And that has not matured yet. We are working with a number of funders in the state who are providing some additional funds to help do that. But what I will tell you is it's been remarkable with the hurricane and with the kinds of patient needs that folks have had in Eastern North Carolina. You can imagine people's homes are underwater, their cars are underwater, people need their medication, all of those things, people getting to their doctors for care, for chronic illnesses and so on. People don't have power. The way that these groups, because they have come together and realized the resources that they can bring together in a more formalized fashion, has had significant impact on the response of Eastern North Carolina to this hurricane. So what I would say, again, with the stewards, is that their opportunity is through those hospital systems, because frankly in our rural communities, the hospital are the leaders, you know, in terms of where people look to for leadership and guidance. And I believe that the providers within those systems of care at this point, it really was the hospital leadership that began to create a conversation. And I think that goes back to some of the earlier points that Sally made, which is a shared vision of value and understanding of the role of providers in the transition. And giving people voice to that, but also a way to understand how that would ultimately lead to better care for their patients. And at the end of the day, that's what I think everyone's most concerned about. And be able to go through some financial models about what that would mean and reduce the number of, or the kind of payment and the pressure that some of the providers felt from a fee-based system. Again, we're not there yet, but those discussions I think are extremely important. And also very important is the provider leadership that's at the table. So this is not something of the foundations coming in and so on. This is hospital leadership and the community care of North Carolina leadership, people coming together and acknowledging they want to do this differently. So those relationships and those community resources to help actually make that happen is where they started. There is a data sharing opportunity that we've been working on. Many of the hospitals are using an Epic system. There's another system that's used for the community care centers or networks across the state, and linkages that are beginning to be created between those two systems, and also at a larger state system, a health information exchange that begins to carry some of the social determinant data that we're trying to get tied back into that data sharing piece, which is obviously very important when we're talking about value-based care and proving those outcomes. The other thing, just in terms of leadership, I know that we'll make it available to you. Sally and the center, the Medical Society Foundation in North Carolina has actually taken up the banner of accountable care organizations, technical assistance and support, and they formed a group called Toward Accountable Care. I believe Sally and the group will, in fact, make that resource available to you, but it does have a toolkit that talks about accountable care in rural communities. So with that, I'll finish my comments and thank you for the opportunity to talk to you today.
Thank you, Maggie, and that's great. I just went to the next slide, which is where we do have the link to the new Rural Accountable Care Guide that you suggested for participants. And there are a number of resources that have been developed, especially focused on rural, and from a variety of partners in the rural communities and within rural technical assistance. So we do recommend looking towards these within your state and both nationally from associations such as the National Rural Health Association, the American Hospital Association, the National Cooperative Health Networks, medical societies, American Academy of Family Physicians. They have started providing resources and videos, as well as federally supported tools and resources, technical assistance available through not only the SHORT program and TASK, but also Rural Health Value, and the Rural Health Information Hub has innovation profiles as well. Also, leadership training for health professionals. Again, it could come from state provider associations and societies, as well as in the national groups like Baldrige, Studer, and universities and foundations. And then new value-based models that are funded by the Centers for Medicare and Medicaid Innovation have resources and are beginning to do evaluations, so that information is beginning to be released as well. And finally, quality metrics and best practices to begin to set goals and targets with your providers. There's the National Quality Forum, the Agency on Healthcare Research and Quality, of course CMS, and then the Rural Quality Improvement Technical Assistance, ARCITA, has a number of quality resources that are linked through the center website. And I'll go back for a moment here. I know Maggie mentioned the Rural Accountable Care Guide. Are there other state organizations, Maggie and Tony Ann, that have been especially supportive of for your organizations and your communities moving towards value?
This is Tony Ann. Oh, sorry.
Go ahead, Tony Ann.
This is Tony Ann. I would say the other one that we've worked with on top of this is for the NCQA measures. We've worked with Qualis Health, and that's through one of our foundation partners. So they've been very helpful about doing some analytics around financial impact of some of those measures.
Great, thank you.
And I was just going to say that the Medical Society Foundation in North Carolina participates now with the National Rural Health Accountable Care Consortium, and they were going to basically create an ACO with some small rural health practices and small private practices with one of the critical access hospitals. And they've found that their work with Caravan Health and the other kinds of models and things that are available to them through the consortium have been extremely helpful in providing them with the capacity to get this work done.
And there were resources that were identified as being needed by rural organizations to help support provider engagement. And the access to claims data was quite key, and being able to share data in like a common platform across the different rural health organizations, community organizations, education, focusing on leadership skills in this new healthcare delivery and payment model, new funding sources focused on rural low-volume providers, patient caregiver involvement in the change to value, a portal to share best practices, and training on using data. So you can see it came up a few different times as really a key challenge that organizations are still trying to cope with in terms of sometimes getting this information, but then how is it analyzed and used for population health. So in conclusion from the summit, we felt rural health providers, especially primary care, really are at the heart of this value-based purchasing and population health management systems. These key strategies identified can help critical access hospitals, networks, and flex programs really focus their efforts on provider engagement to lead communities towards improved health, better health care, and smarter spending. And we have a link there to the full report.